Analgesia and sedation are two closely related concepts that are used to manage pain and anxiety in various medical settings. Here is a breakdown of each. Analgesia refers to the absence or relief of pain. It can be achieved through various methods, including medication. This can be opioid, non-opioid, and other drugs that act on different pain pathways. On-opioid analgesics are increasingly emphasized in a variety of clinical settings as preferred, safe, and effective first-line therapy for mild to moderate acute and chronic pain. Examples of non-opioid analgesics include a variety of agents indicated for a number of pain conditions and carry related potential side effects. The most common used agents include acetaminophen, paracetamol, anticonvulsant including gabapentin and pregabalin, antidepressant including amphetamine and duloxetine, aspirin, acetyl salicylate, other non-steroidal including ibuprofen, diclofenac, naproxen, COX-2 inhibitor. Topical agents include lidocaine and casapsin. Differential among non-opioid analgesic: acetaminophen. The analgesic and fever reducing effect of acetaminophen are well known, but its mechanism of action is not. Nevertheless, it's widely considered to be the safest analgesic available, although liver injury is a concern with overdose. Liver injury is a concern with overdose. Aspirin and other non-steroidal antiinflammatory aspirin alleviate pain and reduce fever and inflammation by decreasing synthesis and release of prostaglandins, which are pro-inflammatory molecule. Cyclooxygenase CO2 inhibitor also inhibit prostaglandin synthesis and release, but unlike aspirin and non-selective non-steroidal inhibitor don't inhibit platelet aggregation. And this is advantage of COX-2. Antidepressant, tricyclic antidepressant, amitriptyline and serotonin, norepinephrine, noradrenaline reuptake inhibitor have unknown mechanism for their pain relief properties. However, studies suggest that their analgesic effect may be related in part of pre-synaptic inhibition of the uptake of serotonin and norepinephrine in pain inhibitory pathway, as well as peripheral mechanisms including B2 adrenergic receptor. Anticonvulsant drugs include gabapentin and pregabalin provide analgesic properties by lowering neurotransmitter release or reducing neuronal firing. Topical treatment: topical non-opioid medications such as lidocaine and casapsin are applied to skin, thus act locally. Lidocaine works by blocking nerve signals that send the feeling of pain from the site of injury to the brain. It causes a temporary loss of feeling in the area to which it's applied. Casapsin appears to deplete local neuron of substance P, which is required in transmission of a non-sedative input. Are non-opioid analgesic appropriate for severe pain? The short-term use of low-dose opioid may be necessary to treat the moderate to severe acute pain that occur after surgery or traumatic injury. However, risks associated with opioid use, including the potential for dependence and overdose, have led prescribers to consider non-opioid analgesic as well as non-pharmacological alternatives such as cognitive behavioral therapy, exercise therapy, and complementary medicine to treat mild or moderate acute and chronic pain. CDC guidelines support this practice, noting that non-opioid medication are generally not associated with development of substance use disorder, and recommendation non-opioid medication and non-pharmacological treatment as the preferred therapy for chronic pain outside of active cancer and palliative and end-life care. Clinical trials also support this strategy. One study of patients with a moderate to severe chronic back pain or hip or knee osteoarthritis pain found that the use of opioid versus non-opioid therapy didn't result in significantly better pain-related function over 12 months. Moreover, those receiving opioid during the study had significantly more medicated-related symptoms over 12 months than those receiving non-opioid analgesic. Non-opioid analgesic in clinical setting. Non-opioid analgesic can play an important role in the emergency department and intensive care unit. For example, double-blind clinical trial found that for emergency department patients with acute extreme pain, combination of non-opioid analgesic may be as effective including pain as opioid. And meta-analysis of 12 randomized clinical trial demonstrated that non-opioid analgesic used as adjuvant to opioid reduce the consumption and the side effect of opioid in ICU patients with Guillain-Barré syndrome, which decreasing patient pain scores. Researchers also suggest that non-opioid non-steroidal antibiotics should become the standard of care of surgical patients to minimize the use of preoperative opioid and to decrease post-operative opioid-related adverse effects such as nausea, vomiting, sedation, alias, priorities, and respiratory depression. This finding align with the enhanced recovery after surgery pathway strategy, which calls for multimodal pain management. The study authors state multimodal analgesia is based on the premise that the concurrent use of primary non-opioid analgesic has additive, if not synergistic, effect towards superior analgesia, which decreasing opioid use and opioid-related side effects. However, they also encourage clinicians to seek continuing medical education and multimodal analgesia during drug-drug interaction and the adverse effect to limit non-anticipated consequences of the practice. Pain treatment strategy. Today, clinicians have a variety of pharmacological and non-pharmacological options for treating pain. For some patients with acute severe pain, a short course of opioid aid in healing and recovery. For other patients with chronic severe pain, opioid provide relief and allow patients to function in their daily life. As the medical community increases its focus on safer, more judicious prescribing and reduce the misuse of opioid. Health care providers are carefully evaluating all available alternatives from opioid and opioid analgesic to mind-body therapies, weighing their potential benefit against the risk. As new studies and trials of non-opioid analgesic are undertaken, clinicians will have additional evidence for their effective use. Non-pharmacological intervention. These include physical therapy, massage, acupuncture, and heat or cold therapy. Regional anesthesia. This involves numbing a specific area of the body with a local anesthetics. Sedation refers to the state of reduced consciousness and or arousal. Can be used to manage anxiety. This can be helpful for patients undergoing stressful procedure or who are experiencing pain. Facilitate medical procedures. Sedation can make it easier for patients to tolerate uncomfortable procedures. Promote mechanical ventilation. In some cases, patients may need to be sedated to tolerate being on a ventilator. Sedation can be achieved through various methods, including medication. This can be benzodiazepine, propofol, other drugs that depress the central nervous system, inhalation agents. These are gases that are inhaled through a mask or breathing tube, such as nitrous oxide. It's important to note that analgesia and sedation are a continuum, and the level of each can be adjusted to meet the individual need for patient. For example, patient may need moderate analgesia to manage pain, but only minimum sedation to remain comfortable and cooperative during a procedure. Both analgesia and sedation can have side effects, so it's important to carefully the importance of effective analgesia. Pain and unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Pain is a personal experience that is influenced to varying degree by biological, psychological, social factors. Analgesia, absence of pain. Analgesia, absence of pain in response to stimulation which would normally be painful, is actually achieved by administration of drug or other methods. Procedural sedation and analgesia, synonymous with the term analgesic. Procedural sedation and analgesia involve the use of short-acting analgesic and sedative medication to enable clinician to perform procedure effectively while monitoring the patient closely for potential adverse effects. Procedural sedation and analgesia exist among a spectrum ranging from minimal sedation with analgesia to general anesthesia. Acute pain has adverse physiological and psychological consequences. Both are important to address early, and one can affect the severity of other. Poor analgesia worsens patient perception of pain both around the time of injury and long after the initial insult. Here, objective of effective analgesia: to relieve suffering, to improve assessment of patient, to reduce physiological stress, to facilitate treatment. Pain is a trigger of injury response, causing activation of complex humoral and immune response, including hyperglycemia, fat, protein catabolism. Physiology of pain: the body ability to detect injury is an important protective mechanism. An individual is alerted to tissue damage by acute pain receptor and nociceptor detect a range of noxious stimuli: heat, cold, pressure, chemical. The initial response is modulated peripherally by altered condition in damaged area, including increased concentration of pro-inflammatory cytokines. Stimuli are transduced to action potential and transmitted to central nervous system, which transmits sharp and well-located pain signal. The more numerous, low, unmyelinated and small diameter C fiber are responsible for transmitting the duller, more poorly localized pain sensation in the spinal cord via the spinothalamic tract. There is fast transmission to higher center on the contralateral side of the injury. From there, axons carry signal to the higher cortical area. Here, the pathway of pain: transduction, transmission, perception, and modulation of a pain stimuli. Treatment of pain: there are no contraindications for pro-hospital analgesia, although some methods may be relatively contraindicated in some patients. Opioid in brain injury may be problematic if they lead to hypercapnia. Good analgesia may assist in monitoring and the treatment of patients. For example, tachycardia used by pain may make the diagnosis of shock more difficult, and ventilation effort and those with rib fracture will be improved with effective analgesia. Patients typically need a combination of non-pharmacological and pharmacological methods for effective analgesia. Non-pharmacological intervention: reassurance through effective therapeutic communication significantly alleviate distress. Professional empathic approach: distract from the painful stimuli Pharmacological intervention. Drug affect the pain pathway at a specific point. Multimodal analgesia describes the action of multiple types of drug working synergistically to produce analgesia superior to one drug acting alone in the higher dose. Multimodal analgesia is considered to be good practice if it reduces the dose required of an agent that has the potential to cause harm. For example, co-administration of paracetamol, acetaminophen, codeine, and non-steroidal anti-inflammatory drug can reduce the amount of morphine required over several hours. Within the time frame of the hospital practitioner, these benefits are unlikely to be seen, and although they are likely to influence a patient's ongoing journey, may prefer a simpler regime of drug. Paracetamol, acetaminophen, and non-steroidal anti-inflammatory drugs. These good analgesics are frequently used in the pre-hospital phase. Use include self-administration inpatient, Entonox, nitrous oxide, rapid onset and offset of analgesia. It's used with other means longer lasting analgesia. Also, mesofuran, bentrox, methoxyflurane is a halogenated ether self-delivered to the patient via an inhaler. It was originally used as an anesthetic agent but now licensed for procedural sedation and analgesia. In UK, it provides rapid effective analgesia and reduces the need of opiate in the pre-hospital setting. Opioids are widely used. Morphine and fentanyl are common and equally effective. Fentanyl is faster acting but shorter lasting. It's more lipid soluble than morphine, so can be delivered via alternative routes. Here, pharmacological intervention, route of administration: oral, inhalation, intravenous, nasal, topical, intramuscular, buccal. Oral, paracetamol, benefit, cost, and easy, widely acceptable, conscious and able to swallow, show onset, poor titration, the limitation, the inhalant, Entonox, rapid self-administration, but there is a limitation, nausea, vomiting, intravenous, non-steroidal anti-inflammatory, opioid, ketamine, paracetamol. The benefit, rapid, non-first pass. Absorption may be affected by mucosal condition. Topical, local anesthetics, painless, poor titration, intramuscular opioid, non-intravenous, slow and variable onset. Buccal, opioid, rapid, painless, avoid first pass. Limit range of drugs. Rectal, paracetamol, rapid, acceptance, the limitation, acceptance from the patient. Intraosseous, non-steroidal opioid, ketamine, paracetamol, rapid, no first pass, titrable, small risk of bone infection. Pre-neural region anesthesia, local anesthetics, lidocaine, bupivacaine, rapid, effective but neuromuscular damage. Mild care. Ketamine is dissociative anesthetic, chemical related to phencyclidine. It's commonly used for anesthesia, sedation, and acute pain, as well for its local anesthetic properties. Sub-anesthetic doses 0.25 to 0.5 mg per kilogram. It provides excellent short-lasting analgesia, sedation, and amnesia, ideal for procedural sedation and analgesia. It has a rapid onset, about 1 minute, and easily and rapidly titrated to effect. This lasts approximately 10 to 15 minutes. Repeated small doses are often needed, for example during extraction of the trapped patient. Though most often administered intravenously, it's effective via mucous route, oral, rectal, nasal, intraosseous, intramuscular. Ketamine has a wide therapeutic index. The difference between the effective dose and the amount needed in overdose to cause significant harm is large. Procedural sedation and analgesia. Some intravenous are distressing for patients because they increase pain. Procedural sedation analgesia aims to relieve anxiety, reduce pain, and provide degree of analgesia by administering short-acting sedation. How much is the patient sedated? Sedation is a continuum, although discrete definitions are proposed. Pre-hospital PSA should aim to be moderate where verbal contact with patient is maintained. Ketamine transcends this definition, being capable of marked change in response to trance-like state while usually maintaining airway reflex. What's required for procedural stage monitoring? ECG, pulse oximetry, automated non-invasive blood pressure, visual monitoring. Here, sedation, responsiveness, procedure, and deep sedation. For moderate sedation, deep sedation, general anesthesia, responsiveness, normal response to verbal stimulation. In minimum sedation, in moderate proposal response to verbal tactile stimulation, proposeful response deep following repeated or painful stimuli, deep sedation. General anesthesia, unarousable even with painful stimulus. Airway unaffected in minimum. No intravenous required. Intravenous may be required in deep intervention. No intervention required. Intervention may be required. Intervention often required in general anesthesia. Spontaneous ventilation unaffected in minimum sedation. Procedure in moderate sedation adequate, maybe inadequate, frequently inadequate. Pre-assessment of patient should include airway assessment, the ability to withstand the hemodynamic effect of drug. Also drugs, numerous agents are available, but whatever drug are used. Guidelines emphasize the need for titration to effect, giving each dose time for full effect before adding more. Polypharmacy should be avoided. Successful PSA can be really achieved for most patients with use of one or two drugs. Titration to effect is easier the fewer drugs are used. Training. Procedural sedation can adversely progress to general anesthesia with association hazardous physiological change such as loss of airway, hemodynamic instability, illness acute or pre-existing, and injury increase the likelihood of adverse event. Ask the patient how bad their pain is, treat it, and then ask them again to see if you have made it better. Distress the patient in pain is upsetting for everyone. Effective pain relief is good for the patient, satisfying for you, and calm the whole emergency team. Non-pharmacological methods of pain relief are very effective. Deep sedation is in practice general anesthesia if you couldn't give your patient general anesthesia. Avoid polypharmacy. Have a small selection of drugs you use regularly and get very used to what they do.